So well-differentiated neuroendocrine tumors, including pancreatic NETs, are generally resistant to immunotherapy, including checkpoint inhibitors. The response rates are extremely low. The rates of high TMB, mismatch repair, or in generic patients are extremely low. So it usually doesn't work, but we also know that patients who receive temozolomide-based chemotherapy, which is quite common in pancreatic NETs, can develop over time MMR-deficient hypermutated phenotype. And so we set out to look retrospectively and see whether these patients treated with immunotherapy may have a higher response rate. And in fact, what we found is that the answer is yes. We looked at 39 patients. It was an international collaboration. All had received prior temozolomide-based chemotherapy, typically capecitabine temozolomide. This wasn't necessarily right after temozolomide-based chemotherapy. It could be years after. It was mostly fairly aggressive tumors, and we know that these tumors can transform and become more aggressive over time. It was about an equal mix of grade 2 and grade 3. But we know that even those with grade 2 may have transformed to grade 3. We just didn't rebiopsy them in many cases. And the majority of these patients had NGS, either tumor biopsies or circulating tumor DNA. The majority of those that underwent NGS had high TMB, and the majority of those that had MMR testing had alterations in MMR genes. And so if you look at the entire 39-patient cohort, the objective response rate was 18%, which is better than what you'd see in a generic population of well-differentiated NETs. If we select for the TMB high, it went up to about 30%. So clearly, this is a population of patients that can respond to immune checkpoint inhibitors. By definition, we selected patients who had received prior temozolomide-based chemotherapy. The majority, and that's either temozolomide in the most cases. So it was actually alkylator chemotherapy. So it was mostly temozolomide, but there were some that received streptozotocin and dacarbazine, which are also similar alkylating agents. The large majority of patients had a response to that prior treatment. So these were patients that were sensitive to alkylating agents, again, mostly temozolomide. And what we can say is that in this population of patients over time, it's clearly selecting for MMR-deficient hypermutated phenotype based on the mechanism of action of the drug. The patients with high TMB had a 30% response rate. Patients with low TMB did not respond. So if you encounter a patient in this situation prior to temozolomide or other alkylating agent chemotherapy, I would recommend checking NGS, checking for TMB, looking for MMR deficient phenotype. And if they meet those criteria, specifically the high TMB, then I think trying immune-based checkpoint inhibitors makes sense. Now, these are typically patients who have received multiple lines of therapy. Options are limited. This is the situation where they may respond. And the median PFS in the patients with MMR deficient was up to nine months. I can say that there were some really exceptional responders, patients who went, who had a near complete response, having had very aggressive tumors. So clearly, there are some patients who might derive very significant benefit. We know from previous data that if we just, treat unselected patients with immune checkpoint inhibitors, the response rates are less than 5%. We know now that, we can say based on this retrospective data that there's definitely a higher response rate in this setting. It's a tough population to study prospectively, but I think you could make a legitimate argument to do a phase 2 prospective trial of immunotherapy in this situation. Now, most patients we treated received combination immunotherapy, specifically ipilimumab, nivolumab. probably works better than single agent PD-1 or PD-L1 inhibitor, but we don't know that for sure. But yes, I think it would be hard to do a randomized study. This is a relatively rare subset of a rare patient population, but I think you can make an argument to do a prospective study in this population.